Okay, welcome back. We're in 15B, so we're in the streaming video. Originally was 15. Now I'm dividing it up into 30-minute segments, so this would be the 15B on this current time because I don't want to renumber all the videos. We left off the previous video with this slide where we were talking about the development of a thrombus, plural thrombi. And by the way, if these things break off or shift over into other areas of the body, they're called emboli. Embolus would be the single and the emboli would be plural. So let's move on. And so if somebody has a diagnosis of atherosclerosis, one of the most common interventions is to put them on some kind of a vasodilator to try to gain up the blood flow to an area that is ischemic. And that's great. I mean, that makes a lot of sense. But there's a little more to the aspect of this, and this phenomenon is known as coronary steel. Particularly in the heart, it's not exclusive to the heart. If you have an area that's not getting enough blood, just a little bit less than what it needs, it's not that the heart that area is dying. It's just that it's not quite getting the oxygen, the glucose that it needs, and it will induce growth of what are known as collateral arteries. It will induce angiogenesis to create new blood vessels to bring additional blood from another area of the heart to the ischemic area. And so we've got our plaque here. What's happened is this area has induced these blood vessels to grow over and supply this area. So we have this plaque, it gets diagnosed, and the clinician says, hey, we want to give you a vasodilator. We think that can help you. And again, that makes a lot of sense. We want to get more blood flow to this ischemic area. But because we have this collateral pathway, there's the possibility of steel. And here's what I mean. In a normal area of the heart, even in resting conditions, those arteries aren't fully dilated. Now, this guy over here is ischemic, so he's sending signals to these arterioles to dilate. So they're at max dilation already, and you're getting blood from the collaterals in order to supply. So if you give a vasodilator, you're not only going to, it can't tell between an affected area and an unaffected area. These arterioles are fully dilated already, so they're not going to get any bigger. But these normal ones over here, which would normally be clamped down a little bit, now get bigger, and now the blood is, by virtue of resistance, is going to go down into this area and not across this collateral to serve this area. So sometimes if you're not careful, and this is one of the reasons why we would want to have eyes and ears on a patient, is that if they go on to a vasodilator, a coronary artery dilator, that they don't observe signs of exacerbation, because coronary steel will actually exacerbate one's coronary artery disease and may actually induce ischemic events or a full-on infarction. Coronary steel. Events like acute atherosclerosis, or perhaps an embolus that shows up accidentally, or that coronary steel phenomenon will induce or can potentially induce angina, which is myocardial pain. And it's very, very, very important. I'm sure you've already had some of this, or you definitely will, is to distinguish what is a severe and serious type of chest pain from a perhaps less serious. So it's a big, big difference if it's actually myocardial pain as opposed to some other type of condition, and leads to vastly different therapies. So non-cardiac chest pain, the key thing is it's often more of a sharp knife-like pain. That can vary in intensity, and usually not associated with other symptoms of cardiac insufficiency. You don't see the pallor, you don't see other signs that they're having trouble, or edema, edema in their veins, what we call JVD. Jugular vein distension, things like that. In any case, the pains that are non-cardiac tend to be sharp, and even if they are referred, and we can see different organs have different types of referred pain in different areas. uh, very rarely is true myocardial pain a sternal pain, if you will. Leading on from that, what we see in non-cardial chest pain in terms of location is that it's localized and it's peripheral. It's usually it can be in any number of areas on the torso. It doesn't radiate, and I've actually had my own experience with this a little bit, not in terms of cardiac pain, but in terms of the bone pain that I had with some broken ribs. It does sort of it feels like an itch that moves on you, but instead of it's kind of it's hard to explain. You'll know it when you feel it. But it radiates away from a center area. It's usually, non-cardiac pain is sharp, it's stabbing. If they have pleurisy, it hurts when they breathe. It kind of causes them to go into a kind of a guarding reflex, if you will. It's usually not related to exercise. Can be postural, can be because of respiration or if somebody presses on it. Um, it's not relieved by rest, and there are lots of reasons why it may manifest or it might affect other aspects of someone's behavior. It tends to be something like a guarding or avoidance type of behavior, whether how they breathe, what they eat, what they do, or how they feel. True ischemic pain, and it's very rarely isolated. I've seen many people with angina, and it always comes with friends, if you know what I mean. It's diffuse. It's not where they can put their finger on where it's coming from. It can radiate all over the place, and women tend to have interesting patterns relative to men. Women tend to get more arm pain or down the back. That's very much something that we see in women that we don't see in men for some reason. It feels like they've got a belt around their chest, and they just can't seem to snap out of it. It feels like they're just they can't put their finger on it, and they just feel lousy. It can be alleviated in some cases if they're on nitrates, or if they just happen to be in a clinic when they have an attack and someone puts them on nitrates, and they are uh, brought to less stress if you get them into a resting position. You can get some relief. But again, they can't seem, they're going to get, because they're in a sort of a systemic ischemia here. Cardiac chest pain is really a sign of cardiac insufficiency or an onset of cardiac insufficiency. And so they're going to feel like they can't catch their breath. They just can't get enough air. And it's, like I said, it's this sort of syndrome, and you would see pallor. It's not the guarding sharpness that we see in non-chest pain. And so, and with signs and symptoms of angina or atherosclerosis, certainly angina is one of the preeminent things. We see this chest pain. It's deep or dull. You can't find a specific location for it. It's spreading and or can radiate down your back or down your arm or shoulder. If you happen to be on electrocardiogram and you have a baseline, that's why I've advocated people who are at risk of coronary artery disease or just want to feel safer to have that baseline electrocardiogram, because if you are in fact having an atherosclerotic ischemic incident, one of the signs that will show up on an electrocardiogram is this ST depression. What we have is the atrial depolarization, ventricular depolarization, and then this sort of sustained ventricular depolarization, a delayed repolarization, if you will. That's a sign that of cardiac nutrient insufficiency, particularly oxygen. And so there are three general types of angina pectoralis. You have what's called a chronic stable angina, which is usually effort related. They call it classic angina. It's sort of a warning sign that, hey, you're overdoing it a little bit. It tends to be, what we mean by stable is that the pain comes and it manifests, but it doesn't get worse. It doesn't vary. and usually resolves with rest or nitrates. Unstable angina is known as pre-infarction or crescendo. What's happening here is that you have some sort of insufficiency that is continuing to remain an insufficiency. Even at rest, there isn't enough oxygen and or glucose to meet metabolic need. And especially at that point, what you're going to see is a sympathetic response. It's going to cause the heart to want to increase its output, increase oxygen demand, and the next thing you know, it's getting worse, even in periods of rest. That's why they call it a crescendo angina, because it continues to get worse. Unstable angina is a true emergency that needs to be dealt with, and very, very quickly. A third variant is known as Prinz metals. It's a very unusual one. It's an artery that doesn't have any overt sclerosis, but for some reason you'll get a trigger, and that artery will clamp down for some reason and lead to an angina type pain. This is a type of angina that will wake people up at night. It's an unusual form, usually self or resolves, or maybe resolves with a little bit of nitrate. So it's sort of in the family of classic, but it's an unusual one because of this, because it happens spontaneously. It's not effort associated. And like I said, it'll wake people up at night. That's where I've seen most of my experience with it. The standard treatment options for angina pectoris are what we call the NBC options: nitrates, vasodilators, beta blockers to slow the heart down, and or calcium channel blockers. So nitrates will vasodilate veins, will help improve what we call the preload of the heart. Beta blockers will help reduce the workload of the heart, reduce oxygen demand, will also lead to coronary dilation. And then thirdly, we have what are called calcium channel blockers, which will again be arteriodilators, thus making it easier for the heart to send blood downstream. So they will also help to mitigate a little bit of the effort of the heart and help it rest a little bit. So vein vasodilators, so venodilators, if you will, lowering preload, reducing cardiac output, and thus reducing demand, and then working on the afterload side of it, the NBC. So other than Prinz metals, beta blockers are indicated, and if it is a Prinz metals type syndrome, beta blockers can actually be contraindicated because they may actually exacerbate the issue. I don't have time to get into why, but it has to do with the opposition of alpha and beta receptors. So in any case, we tend to, unless it's Prinz metals, nitrates, calcium blockers, calcium channel blockers, and beta blockers. The calcium channel blockers and beta blockers are both vasodilatory in nature. Cardiac depressants include the beta blockers and calcium because you're using calcium to initiate cardiac contraction. So nitrates, nitroglycerin is one. You'll often see the drugs have some kind of a nitrate or nitro something in them. Many of them are meant to be sublingual or chewables. Nitroglycerin is very lipophilic, so it can come in a number of different ways. Patches have become more common, but still a lot of people use those sublingual or chewable pills. Calcium channel blockers we'll talk on the next slide. So calcium channel blockers, what they are doing is they are preventing the flow of calcium across a plasma membrane. You do have two major types of calcium channel blockers, L-type, which are voltage gated, and they have a range of voltage that they're active at. These are kind of the big ones in initiating myocardial contraction, but you find them also in vascular tissue. And that's why CCBs are both a vasodilator and a cardiac suppressant. There are T-type calcium channels out there. These are open at a much different voltage, very transient. These guys are more involved with regulating heart rate. So you're going to reduce contractility. You're going to reduce the strength of contraction. You're going to slow down the conductivity of the heart, slow the blood, the heartbeat, thus reducing demand for oxygen. What you're trying to do is break the vicious cycle. As the heart needs oxygen, it will try to pump more blood in order to get more oxygen, but then it needs even more oxygen. So we're going to try to reduce that demand so we can sort of break the cycle. The side effects, though, may be significant in some cases. So we have the blood pressure might be too low. It might give them too much, and so they might have issues with hypotension. They could pass out trying to get up or have a dizziness. They have slow heart rates. It may actually, most of our cardioactive drugs may actually exacerbate previously undiagnosed conditions. So when we put them on cardioactive drugs, that we want to watch for a side effect where we might see a change in the EKG. Headache because of low blood pressure or vasodilation, sort of like almost like a mini migraine, if you will, and then some more generalized things like abdominal discomfort due to perhaps some sympathetic, parasympathetic situations. The edema is due to the fact that you're dilating the blood vessels, and now you've got higher pressures out in the periphery. The three big drugs that are calcium channel blockers, again, these are just three examples. I would call them very nice drugs: verapamil, nifedipine, diltiazem. I don't have the commercial names for them, but you will probably see these, especially if you're working in and around elderly patients. These are very, very common. They become very nice drugs: verapamil, nifedipine, and diltiazem. All of these are calcium channel blockers. So calcium channel blockers are vasodilators, and then there are these other more specific vasodilators that seem to work through modulating the movement of potassium. So they cause potassium channels to open, which then hyperpolarizes the membranes of the smooth muscle cells in the arterial muscle, the arterial smooth muscle. When you hyperpolarize, you can't activate those calcium channels, which are usually voltage gated. Sorry, I'm slurring my words here. Less calcium means less contraction and more relaxation. So we're centering around this idea of potassium in terms of causing smooth muscle relaxation. You let it in, it blocks calcium, and thus you get relaxation. Now, potassium is potentially important in other areas, certainly in cardiac repolarization, certainly in insulin release and or neurotransmitter function. So we will see side effects that may be manifest in the heart, as well as neurologic, or in even some cases their blood insulin. We've looked at calcium channel blockers, we've looked at vasodilators, and so forth. On the horizon, they're looking at some other targets that your book does talk a little bit about, for a paragraph or two, about drugs that may affect what's called the funny current, which is an unstable resting potential inside the pacemaker cells. These things spontaneously depolarize. So unlike a normal cell, which will just stay steady at, say, -70, and then something triggers it to depolarize, some other depolarizing stimulus, these guys do it on their own, and that's called an I sub F. It's a funny sodium current. Well, it turns out that there are also calcium or potassium channels involved as well. Certainly they are in the repolarization side of this. What they're saying is if they can get at these potassium channels here, they may be able to slow down heart rate and thus rest the heart. And so that's what's going on here. If you can somehow decrease the slope of this and get to threshold in a longer time, you'll slow overall heart rate down. without some of the other side effects of vasoconstriction, vasodilation, or overt cardiac suppression. Now, it's one thing to reduce MVO2 in the heart and get the heart rested and dilated and fed and so forth, but that doesn't really get after the real issue, which is occlusion, thrombosis, or if this breaks off and travels somewhere else, what we call an embolus. So now what we're going to do is talk about how we might try to reverse or stave off the buildup of plaques in these areas. And we're going to be looking at molecules like thromboxane A2 moving forward in the next few slides. I'm going to warn you right now that the book is going to get a little technical in this area. I want to reassure you that I'm not going to test you on super technical stuff, but I am going to try to help get you a toehold on this, because understanding it, the more you can understand, the better off you'll be. So when we talked about atherosclerosis, we talked about inflammation and pro-inflammatory stimulus. Well, let's extend that now to the point where the vessel wall is inflamed. It is the architecture has been altered, and you may actually see introduction of proteins that are normally not supposed to be in the plasma showing up, and that will trigger clotting. If you see, they have what's called an extrinsic pathway, which is when the presence of collagen, which is not supposed to be in the plasma, shows up. There are also intrinsic pathways as well. So there are kind of two major ways that you see proteins that aren't in the blood showing up, or other initiators from within the blood. In any case, the key point here is that you're going to get activation of thrombin, and platelet activation can do that. They secrete a number of factors, von Willebrand factor, some other things. Thromboxane A2 is another one we're going to talk about because it's an easy target. It's kind of a keystone, if you will. Once that thrombin is active, it's an active enzyme, so it stays inactive as prothrombin, and then when it gets activated, it facilitates the conversion of a soluble precursor known fibrinogen. By the way, if you see ogen, that means precursor. Here's plasminogen over here. It's a precursor of plasmin. Fibrinogen is the precursor of fibrin. And thrombin, what it will do is facilitate that conversion. This is insoluble, creates an insoluble mesh we can see here in magenta, trapping red blood cells, and now we're getting an overt clot here. Yes, there are other pathways downstream that will hopefully break up that clot, but at this point the pro-inflammatory side is so strong that this fibrinolysis over here gets overwhelmed. You just don't see enough of it happening. So we're converting fibrinogen to fibrin using thrombin. And so this platelet activation, thromboxane release is, in fact, that's why one of the reasons why they call it thromboxane is that it will serve to activate thrombin. So we're gonna work on that. That's how we're gonna go after the therapy. We're gonna get after this. We're gonna get after this, and we may get after some of this a little bit. When you're looking at this figure in your book, it's really complicated, and a lot's going on here, and it's a little tricky in the wording, so I'm going to try to dial it down a little bit. If you have chronic inflammation, what will happen is the endothelium will dysfunction, and you no longer downregulate what are called glycoprotein receptors. These guys over here are receptors that are on platelets. So these circles right here are platelets. So if these receptors are not downregulated, then they will be present on the surface. Okay, so if you don't turn these down, then the on switch is turned on. The platelets will aggregate, and when they aggregate, they will release pro-aggregation factors. That is to say, one of them is thromboxane and ADP. adenosine diphosphate, and that will cause more of these receptors to show up. So more means stickier, more means more activated. So normally we inhibit the activation of those receptors, but what happens is once they are turned on, the platelets will get sticky, they will aggregate, and they will begin reinforcing themselves. So we get this thromboxane makes more receptor makes more aggregation, and eventually we'll get to a point where we trigger the coagulation cascade and thrombin gets activated. Okay, I know that's a lot to swallow here, but the point is that these guys are targets over here. This guy, the thromboxane formation, is a target, and we can also get after the coagulation cascade a little bit over here. So hang with me, just break it down. We're going to go after those receptors that activate platelets. We're going to go after a signal molecule that will activate platelets with bioreceptors. And then thirdly, we're going to try to block this step down here. Okay, it's not as difficult as it might seem when you break it out a little bit. As I mentioned in the previous slides, what are we going to do? We're going to try to do things to shut down the platelets. We're going to get after those receptors. We're going to get after thromboxane A2. So we're going to prescribe anti-platelet medications. That includes aspirin, okay, to try to prevent that clumping of platelets and that activation of platelets. We're going to go after the coagulation pathway. So down there in the lower right corner of that previous slide, these anticoagulants, heparin or warfarin, also known as Coumadin, they will block the sort of proteolytic cascade that's associated with clot formation. And then thirdly, what we're going to do is get after the stimulus. We're going to get after whatever is driving the irritation and dysfunction of the endothelial cells. Controlling the blood pressures is a very common way of getting after it, like beta blockers, ACE inhibitors, CCBs. What they are doing is they're trying to relieve the initial stimulus. So we're going to get after the platelets, we're going to try to block the coagulation, and we're going to try to take away the stimulus that initiated it, sort of surrounding the issue. And the two big targets that we have in the platelets are going to be these receptors, these GP2B, so forth, these receptors here, because they are the sort of the gatekeepers for things like thromboxane. We're certainly going to get after the enzyme that creates thromboxane, and that's cyclooxygenase. So those are sort of the anti-platelet targets that we're going after, or they're the frontline anti-platelet targets. We're also going to get after the clotting pathway. So if thrombin is down here, that's our sort of, I don't have a bullseye. This is about as close as I can get, because again, thrombin is the key enzyme to create fibrin. It's the keystone. Some drugs like warfarin over here are going to block some of the enzymatic steps earlier that lead to the activation of thrombin. Heparin up here is another one. So we'll talk about these a little bit later. Here's the intrinsic pathway. This is inside the vessels. And the extrinsic pathway is proteins that are coming from outside the vessels. So they're really kind of two pathways here. But both of these drugs are getting after that clotting pathway, preventing us from getting here. But again, we're going to talk a little bit more about this in a little bit. That previous slide, all of that stuff that we saw going on prior to thrombin formation is going on during these steps. The release of von Willebrand factor, the introduction of extrinsic proteins or the activation of intrinsic proteins, the activation of those receptors. So we upregulate those glycoprotein type 2B receptors, thromboxane releases, all occurring right here. And those then contribute to the thrombin activation. So they activate the clotting pathways, intrinsic or extrinsic. And so again, here are these targets that we're going to go after. We're going to go after the ones up here. We're going to go after the steps between these two in order to prevent this from happening. Okay? We don't want to clot. All right, so that completes part B of 15. We will pick up where we left off here in the next video, 15C. Talk to you soon.